The last clinical example of today is a palliative spine treatment of 20 grays, 5 fractions, VMAT, daily IGRT with 2 kV images, and no specific positioning accessory. The problem here was that initially we had planned to treat this patient using a 3D CRT, like 2 opposed anterior-posterior beams. And then we decided to use a VMAT technique to treat him. But we acquired at the beginning a simple 3D planning CT. And if we treat it by VMAT, we should have acquired a 4D scan that would have taken the respiratory motion into account. And we should have planned everything on the average intensity projection. So here are the results of the VMAT plan at the first fraction. And you can see that we have a huge underdosage in the inferior part of the lung. We were wondering why. So we planned a CBCT acquisition at the second fraction, and you can see that on the CBCT, so on the right of the slide, the densities in the inferior part of the lung are completely different than in our 3D scan that we acquire because we plan to use a 3D CRT treatment. So because of this density difference, the delivery of the plant was so different with this underdosage behind those high density structures. At this point, we decided to quickly replan the plan using 3D CRT for the last 4 fractions. And because I told you that for 3D CRT, we still use our old diode measurement system, I do not have the result to show you. But I think that without the in vivo module, we would not have acquired the CBCT for a palliative 20 gray treatment, and we would not have seen this problem for this patient.